Hi everyone, welcome to 1 p.m. Just a reminder that you're listening to the summary version of this discussion. We present the first principles of the condition so that you can derive the clinical features and management. If you want to listen to the longer form of our podcast, where we engage in some friendly banter, given the liberty to ask stupid questions, and discuss the first principles in more depth, check out the stupid questions version. If you're at the right place, enjoy! So, the first principles of stroke and how this relates to clinical features as well as management. There are two first principles that we think are important for your understanding of stroke. The first is Virchow's triad. And what are the three features of Virchow's triad? Well, first, we have the hypercoagulability of blood. You find this in cancer, inflammatory disease. Second, we have blood stasis, and you find this in immobility, varicose veins, and venous obstruction. Third, we have endothelial or vessel wall injury, and you can get this from surgery or chemical irritation. So that's the first principle that you should get your head around. The second relates to the brain regions. The brain has 4 brain lobes, and an important or a useful way that we can use to remember this is by understanding the Hal homunculus, and this relates heavily with their clinical features that we will talk about. So now imagine a human called Hal, H-A-L, and he is lying horizontally across your brain. His legs are in the middle part, and then his head is hanging off. So the head, H stands for head, A stands for arms, and L stands for legs. Now, also quite fun is that the brain is mainly supplied by 3 cerebral arteries. So at the bottom, you have the posterior cerebral artery, and this relates to the H of the Hal. So if you have blockage here, you're going to get vision loss. So contralateral homonymous hemianopia. In the middle, we have the middle cerebral artery, and if you get blockage here, you're going to relate to the A of Hal, and this means that you're going to get upper limb, arms, contralateral weakness, and sensory loss. Finally, at the very top, you're going to have the ACA, which is the anterior cerebral artery, and if you get a blockage here, you're going to have a lower limb contralateral weakness and sensory loss. So we talked about the main features of the clinical features here is that you're going to get contralateral features because if you recall about the neuronal pathways, you're going to get decussation of the pyramids. In terms of the clinical features and symptoms, this mainly is defined by the affected vessel. So when you think about their clinical features or you're taking a history, you want to relate this using the Hal homunculus and the relationship with their cerebral arteries. So a bit more about this. If we get the anterior cerebral artery, and we were talking about just now, the L corresponds to the lower parts of the body, right? You're also going to get limb apraxia as well as urinary incontinence. If you get the MCA, which is affected, and this relates to the A of Hal, which is the arms, you're going to get upper limbs are more going to be affected than the lower limbs. You're also going to get aphasia over here. You're going to get Broca's aphasia as well as Wernicke's aphasia because this area is also supplied by the MCA. And finally, with the PCA, this relates to symptoms related to the occipital lobe, and that's why with H standing for head, you're going to get quite a lot of vision loss as if you get the PCA occluded. Now, a bit of summary about the management. The first thing that you should do when the patient comes in is A, B, C, D, E. Doctors A, B, C, D, E. So you have to assess the patient, clinical assessment, and make sure to rule out other causes such as stroke mimics. Now, assuming that we've moved down the pathway and we have a clinical suspicion of stroke, the first thing to do is to do a NCCT, a non-contrast head CT. And the purpose of this is to exclude hemorrhage, stroke mimics, or any other signs of early infarction. The second thing to do is to do a neurovascular imaging, i.e. angiography. So you want to confirm the presence of a large artery occlusion, and this is helpful for patients who are candidates for mechanical thrombectomy. And finally, you're going to do perfusion imaging. And so the purpose of this is to depict the infarction core as well as the ischemic penumbra. And so if you know these findings can help you influence your treatment decisions, whether or not you do mechanical thrombectomy or whether or not you have IV TPA. So finally, if after all these things, what you should do, and if you're within the 4.5 hours after the stroke symptoms have started, you should inject TPA, usually given through a vein in the arm within the first 3 hours. So that's pretty much it. That's the quick summary of our discussion on the first principles of stroke. Hi everyone, thanks for listening to the 1 p.m. podcast. We try our best to provide up-to-date information, but please let us know if we missed anything. We welcome any feedback, comments, and suggestions for topics. In the meantime, check out our Notion, link in the description, where you can find an article about the topic and free Anki cards for you to study. That's all from us. See you next time at 1 p.m.